Hey there, I'm Dr. Jill Wener. I'm a physician, a meditation teacher, a tapping instructor, an author, and an aspiring anti-racist, which requires consistent self-evaluation and questioning and deep work. And I'm so excited to have Dr. Nicole Peoples here with me today. Dr. Peoples is one of my dearest friends and also a mom and also a doctor, and she is a mom of a child with sickle cell. And so we've had plenty of conversations about race over our friendship, and the deeper I've dived into racism and the way it pervades all the systems, I've been thinking a lot about healthcare and realizing that sickle cell is just one of these diseases that is so racially charged, and such a big issue that I think a lot of people can learn from. So Nicole, thanks for being on the podcast, on the show, and welcome.
Oh, thanks. Happy to be here.
So let's talk. I guess let's start with, how old was your daughter when she was diagnosed?
At birth.
At birth.
They do, around birth, within months of her birth. They do regular screenings.
Mm-hmm.
And I knew that I had the sickle cell trait, and my husband had thalassemia trait. And when you put those together, you get a form of sickle cell. So sickle beta thalassemia plus is what my daughter has. So it's a little different, but we knew ahead of time that it was a possibility that she could have sickle cell.
Okay. And so what has it been like for you as a mom? I mean, you can't separate the doctor and the mom in there. It's all together, but I'd like to get a sense of what it's been like for you to be the mom of a sickle cell, a child with sickle cell, and like what your experience has been like with the healthcare system, how it's changed the way you've seen the way that people with sickle cell are treated.
Yeah, so, as a mom, getting any diagnosis of a child, I mean, it's scary, right? And coming into it, sort of knowing what sickle cell was, it helped and hurt how I felt about it. It's like I had probably more knowledge than most people about the disease when my daughter was diagnosed, but at the same time, I just know what that looks like over the trajectory of a lifetime and what sort of interactions my daughter would potentially have with the healthcare system. And that really scared me. I mean, that really, more than anything else. And sickle cell is a unique disease because it is sort of pinned by its pain, right? That is the disease. The disease leads to chronic recurrent pain. And obviously as a mom, you don't want your child to be in pain for any reason. Right. And to know that she has a disorder that could lead to just random pain. I mean, that was terrifying as well. So yeah, I think from a mom's side, it was more of just the fear of what potentially suffering she would go through. And from a physician perspective, it was more of, oh my gosh, no, I don't want her to have to interface with the healthcare system.
It's for anyone listening who isn't medical, can you talk a little bit about what sickle cell is, and obviously the risk factors for it, and the patient population who gets it?
So sickle cell is, sickle cell is a disease of the blood cells, and basically your blood cells have a particular shape, and that shape allows them to go through the blood vessels. And then if the shape changes, it can clog the blood vessels, and if you clog the blood vessels, you reduce blood flow to a specific area, and that can lead to pain. So, the people who typically get it tend to, well, it's a genetic disease, so you have a genetic predisposition to get the disease. And so if both of your parents have a trait, and you get both of those traits, and you end up with the disease. Now, there are some people who just have the trait, like myself, where I can't say for myself I've had any symptoms of sickle cell, but there have been people who have stated that even with the trait that they've had symptoms. But typically, that's how you get it. There's no other sort of risk factor for it. And it typically affects people of African American descent and Mediterranean descent. So you'll see it, particularly in America, you'll see most of the people who have sickle cell be African American. But it's also highly prevalent, as you can imagine, in Africa, but also in the Mediterranean.
So right away, it's already something that like in our country, only Black people have. So it's already kind of putting itself in this category of like race is already there, even,
Yeah.
explicitly.
Yeah, I mean, I want to clarify, it's not only Black people, but majority of people are Black. And when you learn about it in medical school, as you could probably remember, it is a disease that we categorized as, as Black people, right? So Black people have this disease. There are other diseases that other groups, are more likely to have. Sickle cell has always sort of been attributed to being African, people of African descent.
Do people in the like of Caribbean descent have it, or is it like, is there common?
Yeah, so, and I haven't really looked into this. I guess the prevailing theory is it's sort of survival of the fittest. So I think at some point there's a theory that because it protects against malaria, so that is the one thing that sickle cell does do. It protects people from developing malaria. Malaria is a disease that is
Endemic?
endemic, sorry, to the African continent. And so that's why sickle cell was able to thrive in that area. So if you look at sort of evolution and genetics, that's the theory as to why it's prevalent within our genetic code more than other people's genetic code. So because it prevailed in our society because it had a protective component. But I honestly, I haven't looked into, whether or not that's in fact, evolutionarily true.
Is what
But
it, like, who knows?
And that's what we were taught. So, I mean, so that's what I know about that. But yes, so if you were to look at people, Caribbean Americans or Caribbeans in general, then they would also have that same genetic code.
So you from what you've told me, like your daughter has not had a whole lot of sickle cell crises and interactions with the healthcare system, but in the ones that she has had, what have you noticed about the way she's treated, and how is that what has that taught you about the treatment of these patients, and also of the racial and racist implications of it?
I think, the first thing is I have to sort of give the little backstory about sort of how I've seen sickle cell be treated as a physician. And how that has sort of colored my lens of how my daughter is treated or potentially can be treated. And so as a clinician, we know that pain, I guess everybody doesn't know this, but pain is often undertreated in people of African descent. Historically, there was a theory or a thought that Black people had a higher pain tolerance. So pain didn't affect them the same way it affected white people. This goes back to, hundreds of years ago in medicine where, Black people were, the research was done on them, and, they were, surgery was done on them without anesthesia because of these theories that Black people had a higher tolerance to pain. It wouldn't hurt them the way it hurts everyone else. And that sort of theory has kind of been pervasive within the medical system. And so you take that, and then you add on top of that sort of the perception of Black people and drugs. So another perception within our country is that Black people use drugs more. And so when they come in contact with the healthcare system, they're seen as people who want to take advantage of the system to obtain drugs. So you take both of those things and you work in a hospital that is heavily populated with Black people, you're going to come across people nurses, other doctors who treat patients a certain way based off of those preconceived notions. And so I saw that a lot in my training. I've seen how Black people are not considered to be, oh, that person is lying about their pain. They're not really in that much pain. You see that over and over again. And you see that they're undertreated, right? So you see that they're prescribed left pain medicine. You have nurses who will have the order to give pain medication and still not give it. So that sort of is the backdrop. But then you add on to that a disease where the treatment is pain medicine, right? And even more importantly, understanding how to manage sickle cell disease is in itself a sort of a subspecialty, right? So if you're reading the literature says that you have to give a certain amount of pain medicine to sort of prevent the pain from getting worse. So you have to give high amounts of pain medicines early on. And most doctors don't know that. And so what they do is they treat sickle cell patients the way that they would treat anybody who's in pain, and that's inappropriate. And so you'll see even there's studies on this that show that people with sickle cell are undertreated. Their pain is consistently undertreated. So I knew all of that going into this with my daughter. But I also knew that as a resident and early on in my career that I also had those same preconceived notions. Like I didn't quite understand how to treat sickle cell. I didn't know how aggressive you needed to be, how much pain medicine to give. And so I can say for myself, I probably undertreated people. And so one of the things that was really sort of shocking to me is that you'll see that not only are these patients undertreated, but then they're stigmatized, right? So when they do come to the hospital for pain management, that's the reason they come, because they're in pain. When they come to the hospital for pain management, you'll hear nurses say, talk about them in certain ways. And I just remember, being a hospitalist working in the ER, I would admit patients from the ER, where nurses would say, oh, she's not in pain. Or I'll get calls in the middle of the night saying, she's, asking for pain medicine, but she's on her telephone, or she's watching a movie, to insinuate that she's really not in pain. Mm-hmm. So then when my daughter had her first crisis, the thing that I would do, or the thing that I learned, was that I had to distract her with things like TV, or I'd have to distract her by talking to her, or giving her something to get her mind off of the pain. And that was my first realization that, pain medicines aren't the only thing that help you get out of pain. There are a lot of distractions and things that you can do to kind of, modulate your pain. But when I thought about that, I thought about all the patients who were doing that. Whenever you go into a sickle cell patient's room, they're usually doing something. They're usually watching TV, they're on the phone, they're doing something to keep themselves active so that they're not thinking about the pain that they're chronically in. And it wasn't until I experienced that as a mom of a patient with sickle cell that I realized that I was stigmatizing, and that all the nurses were stigmatizing, and all these other doctors were stigmatizing their patients for doing what they needed to do to get their pain under control. And then sort of the last component of that perspective is that the patients also know that they're being stigmatized, and they also know that people will undertreat them. And so they become upset that they're in pain, and this particular doctor on this particular day doesn't know how to treat their pain, and other doctors do know how to treat their pain. So they're trying to dictate to the doctor, listen, this is how my pain is treated. If you give me this medication works for me. And so when you, as a physician, you know how this turns, when a patient starts to tell you what they need and how they need it, and particularly when it comes to pain medicine, you automatically, put them in the category of drug seeker, right?
Yeah, all that.
Automatically. And so then that changes your behavior again. So, having a daughter with sickle cell, having to go to the hospital and having to have them give her pain medication was actually really hard for me. I didn't want my daughter to get pain medication because I didn't want my daughter to be that patient in 5 years and 10 years and 20 years who was so addicted to the pain medication that whenever she went into the hospital, nobody believed her. That she, I wanted to shelter her from addiction that is inevitable, when you are on chronic pain medications your whole entire life. And so, this has been a really difficult thing to navigate, trying to be a mother and a doctor of a patient who has chronic pain. And I think, me clinically, I don't have, in the very beginning, because I was very reluctant to give pain medications, and I was dealing with a lot of pediatricians, doctors who were used to dealing with patients with sickle cell. Pediatricians tend to know more about sickle cell than adult doctors do. they kept, you know, they would keep offering me pain medication. I remember the very first time we went, they kept offering me pain medication, and I kept saying, can we give Tylenol? Can we give Motrin? And they were like, no, we can give Dilaudid, we can give fentanyl, these stronger medications. And I was really reluctant. They were the ones sort of pushing it on me, until I realized, no, my daughter is really in pain. If I don't treat her, then she's just going to get worse. If I don't give consent for her to get treated that way with these strong addictive medications, my daughter's going to suffer. So it's been complicated, you know, trying to navigate my own mind on this, coming as a physician who didn't quite understand to being a mother who was forced to understand. And, you know, I think I've been a little bit luckier than most because I understood how the healthcare system worked. And I also knew that typically I would try not to tell the nurses and the doctors that I was a physician, because I didn't want us to be treated any different, but it's in my chart, they knew. So they would always come in and talk to me like a doctor as opposed to a mother. And that was also very hard. But because when you're a mother, you just want to be a mother. You don't want to be your profession, you know?
Wow. So yeah, I mean, it's like looking back, like I have this 2020 lens now. It's not even 2020. It's like 20 something better than it was, but I'm still refining it. Of all of the microaggressions that I've committed in my career, my medical career, I left 5 years ago, well before I had learned much about, I learned nothing about systemic racism, to be honest. And like my own contribution to it, because I was like, I'm liberal, it's fine, I don't count, you know, like I don't contribute to it. And so like looking back and being like, because like these patients will come in and they'll be in the hospital for like sometimes weeks at a time getting their pain controlled, and there's this balance between like they're in pain and then they're like talking to you but slurring their speech and like walking to the bathroom but about to fall over from their pain medicine, and you're like, are they going to overdose? Like this is clearly a sign to me that they're drug seek, you know, like we use these clues that might work for other patients but don't work with sickle cell population, because their bodies deal with pain, like and pain medications differently, because it's been a chronic thing. So we can't use the same context clues we might for someone who comes in when pain for something else for the first time when they're 35 years old. And there were arguments and like feeling like I was, you know, like, cause you're taught in med school, like don't give pain meds unless people need it, cause they're going to get addicted. Yeah. Don't give antibiotics unless, because they're going to get resistant. And so it's like this battle from the beginning. So what do we do as healthcare professionals? Like, how can we be better? How can we be more compassionate and recognize the way that we're harming people?
I think, so the first thing I want to say is that when you said that the patients might be there for weeks at a time, sometimes they're in there for weeks at a time because the doctors that are managing them aren't managing them right. If they had done what they were supposed to do in the very beginning, then they would have gotten the pain under control and then been able to taper the patient off. But so oftentimes the length of stay is a result of just inadequate knowledge on the behalf of the people prescribing medications, which is sad. But I think one of the things that popped in my mind when you were talking was that this is ingrained in the way we're taught, right? It's as clinicians. And so it's not just you as a white woman treating Black patients, it's Black, you know, doctors treating Black patients. It's, you know, we have to sort of be aware of, you know, our own biases going in. And we also have to be aware, have a better awareness of the disease that we're treating. Again, sickle cell is one of those diseases that possibly because it's one that affects African Americans more than other groups, it may not be something that a particular doctor has actually read up on since medical school. They haven't read the current literature on it. They haven't found it to be relevant to their current practice. And so, or it's just not as important, right? Like, oh, I know how to manage pain. We make assumptions about our own capabilities as practitioners. So I think the first thing we have to do is we have to, number one, be aware of our biases. Number two, be aware of the disease that we're treating. And then check our biases at the door and say, okay, would I treat this person differently if they, you know, if they were a different color, or if I understood the situation better. I think there's also cultural differences that also play a role. And so if you don't understand the culture of what it means to be Black in America, interfacing with the healthcare system on a regular basis and being in pain, then I think that's where social sort of competency comes in, to sort of understand that the patient may already come in with preconceived notions about how they're going to be treated, because of how they've been treated before. So even if you're a well-intending doctor, doesn't mean that every other doctor who treated that person before was well-intending and did their job correctly. So that patient's going to come in the same way you would come in, a little guarded about sharing information, about expressing their pain, because they don't want to, they've been interfacing with the healthcare system since they were children. So they know the drill about sickle cell better than you do. Just say that off, unless you've got sickle cell or you specialize in sickle cell, they've experienced it. It's oftentimes physicians have a hard time recognizing that maybe the expert in the room is actually the patient. So I think that is, pivotal, particularly when treating sickle cell patients. And then I also think that we have to do a better job of checking our colleagues. There are numerous occasions where I've had to go and tell, when I overheard people talking about, the pain seeker in room 5, or, where I would have to say, listen, this person has sickle cell. She's in chronic pain. She's been on pain medications since she was a child. And of course she has issues with addiction. Of course she's dependent. Of course she's built tolerance. You have to understand that when you're treating these patients and not label them, right? And it's not just sickle cell. Another one I see this often in people who are in chronic pain where they get dismissed often is type 1 diabetes. And the reason is because it's another disease where these patients have been on medications or maybe been in the hospital numerous times and interfaced with the healthcare system numerous times. And by the time they get to you as an adult, they also have some biases, right? They also are going to assume as a practitioner, you don't care, that you're not invested, that you're not going to treat them appropriately, that you're going to judge them. So I think it's really important that we understand that population better, understand the disease better, and understand ourselves better when interacting with those patients.
Oh gosh, it's so, God, the number of times I've been like, yeah, they're whatever. They say they're in pain, but they're on their iPad, they're on their phone, like that, it's so ugly. It's so,
we've worked in different places. I said it's so common that we've worked in different places, but the experience is exactly the same, right?
Yeah, absolutely. And I mean, you and I have had conversations and I'm like, oh, they're distracting themselves. Like, like, of course, but why don't we think that? There ends up being this like oppositional battle a lot of times in medicine. And I think, I'm just thinking about the trauma, like the trauma response that these patients with sickle cell, who we will call sicklers, which is horrible on its own. So like, do you have a preferred way?
I mean, I think with all people, we should just refer to them as,
people with
their name would be work. I haven't really thought about, do I have nickname? I tend to refer to people as patient, the patient in room. But that's more of a HIPAA sort of thing. You don't want to go around saying people's names in public spaces. But yeah, I mean, that's just something I think we have to be cautious of as well. It's like giving labels to people that takes away their humanity.
Yeah, as you could say sickler to any doctor, and they're going to have a response.
Yeah,
and they're going to have all these things lined up of what they believe about that patient before they even walk in the room. I bet we could survey, and 9 out of 10 doctors would have that, if not 99 out of 100 doctors would have that. But
I think because it's hard on the physician side, it's hard on the practitioner, on the nurse's side, on the practitioner side as well, because we don't understand, right? I think that's why, when you say something like that and you say, oh, it's, 99 out of 100 will all have a response, or a visceral response, because we're so unused to and so used to not addressing the fact that we don't know anything about what we're doing when it comes to sickle cell disease, and we're not treating it, and we refuse to admit it, that we all have this visceral response. Now I have a much more compassionate response, right? But of course, it took me having a child with sickle cell to sort of recognize, maybe my biases are showing up here. And those biases aren't just my biases, they're the biases that were passed down. Like it is taught to be biased against sickle cell patients, right?
Yeah.
You're taught the same way you're taught to be biased against people with substance abuse issues, right? So yeah.
I think about the trauma that is accrued over a lifetime for patients with sickle cell, and how that informs their response. Like you're saying, they're, maybe distrust, or they're going to come in a little upset that they're going to be undertreated, and then also almost the trauma response of the doctors from being, our training is brutal. And so what happens is, instead of like wanting to have patients so we can take care of them and make them feel better, we start to like resent having one more patient to take care of. And the notion of having someone that may be there for a long time, or that, like, we have our own trauma response, and it's not like, well, poor doctors, but it's like something to think about after doing the punishing hours and schedule of residency. A lot of medical school is that way. Like, we're coming in with our trauma, and then these patients are coming in with their trauma, but they're like they're not like,
so
they don't match.
And they butt heads. But I think that goes back to our training, right?
Yeah.
Because we are supposed to be compassionate people. And we're expected to be compassionate people. But then I would say, to some degree, you're given a pass when you come in contact with a difficult patient. And who falls into that difficult patient? It's usually people who have, it actually comes in all the things that you would come in contact when you come in contact with the sickle cell patient. So it's that patient is already may have some hostility because of their lifelong trauma of having to interface with the healthcare system. They're in pain, so they're giving the drug that we're told we shouldn't be giving, that we shouldn't give a lot of, that if we give too much of it, that we could be penalized for it. So you add that on top of it, and then the patient's going to be there for a very long time. And so you have to deal with that. And then on top of that, you add in the fact that the preconceived judgment is sometimes baked into the way you were trained to treat it. So you add all those things in there, and that becomes a difficult patient. And with anything, anybody's going to have a visceral response to that, unless you're taught how not to, right? So we're not taught not to have a visceral response, how to deal with patients who might be dealing with chronic pain. We're taught the exact opposite, that these are going to be difficult patients, and that, it's going to, you're going to have to be in constant battle with them. And then you go into the room and you are in constant battle. So that makes it even more difficult, right? Because you come in defensive and they come in defensive. So yeah, we have to do better. Our job is to remind the patient that we understand that they are in pain, and that our goal is one and the same with them, is that it's to get their pain under control. We also understand that, when you're in pain, you may not be nice, and it's okay. Like, I'm here to take that burden. If anything, I understand if I come in the room and you're not as pleasant as I want you to be, just, take a moment and think about how pleasant you are when you're in pain, right? And it's like you're putting this, you want them to have more resiliency than you have, and they're the ones in pain, So I think that's just an unfair expectation.
Absolutely. That's so helpful. So for doctors coming in, checking your biases, being aware of the disease. This is all stuff that you said, so I'm just kind of recounting it. Being aware of the disease, like, read up on it, make sure you're actually doing the most up-to-date guidelines. Understand the cultural differences. And the distrust isn't because Black people are distrusting people. It's because white people have done so many bad things to Black. We didn't get at this, but it's important to say that the healthcare system has done so many things society has, but specifically in the healthcare context as well. Tuskegee, you know, so many different bad things to Black patients that the distrust is there passed along. It's a cultural thing, but it's totally understandable. So understanding that and then
But it's not
checking.
just passed along, it's then reproduced, right? So
Yeah.
though you have these big major things, like I think the father of OBGYN was given that title because he did these experiments on Black people,
Yeah.
Black women without anesthesia. There are those big things, right, that happened a long time ago. But then the culture of medicine has not changed that much. I mean, one of the things that I think is actually really interesting is that how we, the very first thing you learn in medical school is how to sort of, or when you're presenting a patient, is to give their, you know, name, their age, and then their race. And that always threw me for one, because I'm like, why is their race important? Like, if you think about it, it's not really important. And the reason why we do that is because a long time ago in our culture, in the medical culture, we needed to know their race to know that, you know, how to treat this patient, right? So if you worked in a hospital where they had Black and white patients, it was important to know that this patient that you just are talking about is a white patient I'm supposed to treat this way. And this person is a Black patient who may not get the same treatment, may not get the same level of care, may not have the same thing. So that whole idea of adding race in there shouldn't be there anyway, yet we still teach that to medical students today.
Yeah.
So that, I think, it's not just the things that happened in the past.
Yeah.
It's how we still structure healthcare.
Yeah. That's so powerful. And I was also like, because we're taught that it's like, well, certain patient populations, like for example, a lot of times people who were born and grew up in Asia can have hepatitis B transmitted to them. I know you know this, but for people who are listening, transmitted to them from birth. And it can cause, so you would want to know theoretically that someone is from Asia, you know, Chinese or from somewhere in Asia, because they'd be at risk for that if you're talking about they're coming in with like liver related complaints or something. But that's not how it's used. Like that's what we're taught that that's what it's about, but it's not at all how it's used. And you're blowing my mind right now. I didn't realize that the origins of that was sort of like, well, they're white or they're Black, so they're going to go have this treatment or that, but it totally makes sense. It's just we don't get taught that.
There are situations, like you said, where it is important, but it shouldn't be standard, right? It's not like something that you need to know about every patient that comes in. If it's relevant history, but it's not relevant in most of the cases.
Yeah. And the other thing that happens is we only say it when they're not white. What ends up getting passed through is like we assume they're white unless you say that they're not. Like I don't know how many times I've heard, you know, a 55-year-old white female or Caucasian female versus Black female or Asian or some, you know, some other ethnicity. So it's just another example of the like pervasiveness of whiteness.
And it's kind of triggering almost. I mean, to me, it's kind of seems because
Sure.
the moment you say Black, I think then you start to formulate an opinion, right? Like if you have biases that are even, you know, that are conscious or unconscious, the moment you give that detail, you start to play to whatever biases that whoever's listening to, right? So you say Black female, and then you say is coming in with pain. Well, automatically that's gonna, if you have biases, which most of us do, that's going to trigger something. If you say Asian, if you say this is a 45-year-old Asian female or particularly Asian male, we're taught, you know, in these cultural competence arenas that there are certain things we're supposed to attribute to like Asian Americans, that they're stoic and they don't show their pain. They may be in pain, but they don't show it. And this is important to know. However, now what we've done is we've now added a bias that may not be generalizable, right? And so you see somebody and you just make these assumptions. And I think that's dangerous, right? Particularly for people who aren't trained to be able to use these things. If we're just, a lot of times in cultural competency, we're just sort of cutting the surface of things that we should possibly think about in a particular patient population. But if that person who you're teaching isn't really aware of the complexities of a cultural group, then they may be using those biases inappropriately. For example, Oftentimes when people talk about Blackness, they talk about poverty. So the moment you say Black, somebody might be associating poverty to it. So they assume that every person who's Black is impoverished or may not have good access to healthcare or may not, so I think it's a tricky situation. I think our training has to be more comprehensive so that we're not giving people biases to think about the moment that you use their race.
Right, right. And also not to forget the like countless systemically racist policies that have led to that perception of poverty and that reality of poverty for a lot of people. That's not because it's Black. Like that's because racism made it that way. So yeah, and we don't learn any of that. I don't remember learning any of that. Yeah, it's so interesting. So for my conscious anti-racism course for healthcare, a doctor named Stacy Schmidt, who's at a local county hospital here, she did a video and on social determinants of health, which are these sort of social things that can lead to health issues, and they come up a lot in patients who have been marginalized by our systemically racist society in various ways. And she starts with a case study. It was so brilliant. She was like, 48-year-old guy, scheduled for your outpatient clinic. He's been a no-show the last 2 times. He's here, last visit, he was noted to be non-compliant and wanting pain medication for his chronic such and such. And he's coming in to see you today. And it says something about his, like, maybe about his education, maybe not. And she's like, reads the case, and then she's like, okay, ask yourself in your mind, is this patient Black or white? And I was like, oh my God, she didn't say race. Like, she didn't say Black, but my brain automatically assigned him to that. And I know that I'm not the only one that happens to, because she wouldn't have made that example otherwise. But like, she's like, what are you making assumptions about his education level? And what are you this? And it goes into talking to people to understand more why they are, what has led them to come in the state that they're in, and understanding their adverse childhood events and all these other things. But it was just so powerful. It was like, oh crap. Like,
I was like, I failed.
I failed so hard, but it was so eye-opening, because it's like, we all have it, and it just is a sign that we need to work on it. And it's in us. It's not out there. It is out there, but it's also in us, and us meaning white people. And I can't speak for Black people, but you were just saying before that Black people, medical professionals, you have a lot of the same biases.
We hold biases, and we perpetuate racist ideas. We're trained in the same schools that you're trained in for the most part. I mean, with the same sort of educational biases, right? And if you're not raised in an environment where you're getting the counter information, right, where you're learning about all of these racial disparities and how that they play a role in the lives of Black people, if you're not in an environment where that's part of the education as well, you're not immune from having those biases, right? Which is why you see so many, people who are Black who also go along with racist policies, right? So I think it's important that it's more likely that Black people may have a better understanding because they may have gotten that education from the home, but they definitely didn't get it from the school. And we went to the same, we had the same curriculum when we talked about history.
Yeah.
So.
Yeah.
And I think without that consciousness coming into, primary school, and then again into secondary school, and then into, colleges. And by the time you get to medical school, gosh, you've lost so much opportunity to check your biases, and those biases are much more ingrained. And then we assume that the doctors, because of their level of education, that somehow they're immune. That just seems kind of ridiculous.
Well, because then you're adding in the God complex and the like paternalism and all of that stuff. So it actually, I think,
exacerbates it,
makes it worse. Exactly. And for doctors listening, like, it's not your fault, but it's real. It's a thing. So yeah. So, and then, gosh, and then, so going, I mean, this has been so incredible, Nicole. going back to the way to shift your approach to your patients is like coming in there with a common goal and being like, I know that, like understanding their pain behavior may not look the same as other people's pain behavior. And like my goal, like reassuring them, my goal is this, to get your pain under control. And I love that. It's okay if you're not pleasant. Do you suggest that people say that like out, like explicitly?
I typically don't say it out explicitly, but when people are not pleasant, I reassure them that it's okay.
Yeah. And
I,
maybe,
yeah, I mean, I just tell people like I understand that you're upset, and I would be upset too if I was in pain. So let me try to handle how to get your pain under control, and let's see if we can work together. And I didn't add this, but you can ask the patient for their help. I do that often. Like if they're upset, you acknowledge that they're upset, and then you say, what would make the difference for you, right? What am I missing? Or what is it that you were looking for me to do that's not being done? And the other thing I always do for my sickle cell patients is I ask them, I lead with, how has your pain been controlled in the past? What medicines worked for you? Because here's another thing that I don't think doctors know all that much about, is that all of our bodies, we process pain medications differently. We have a different system in each of our bodies based off of our genetics that allows us to respond differently to certain pain medicines. So when a patient says, morphine doesn't work for me, I don't think that they are just blowing smoke up my ass. I actually know that it's very possible that they have the genetic variation that doesn't activate, the drug into its active form. So I think, again, that's education. I think most doctors were taught that, but they don't know how to apply it. And if you know that and you understand that, then you're more apt to ask your patients who have pain, not just your sickle cell patients, but people who have been on pain medications, what have worked for you before? What pain medicines have worked? Because they can, particularly as sickle cell patients, they can tell you how to treat their pain, what worked. And I've had patients say, I get Dilaudid every hour. With breakthrough pain, I get, Percocet or whatever it is. And if that's what's worked for them, why are we so reluctant to do that for them? And if you look it up in the evidence, it shows that giving Q1 hour pain medications in sickle cell patients is not uncommon. So I think that is also something, and acknowledge their pain, but also ask them for their help.
like, what are we holding on to so damn tightly? Like, it's like, I must be the steward of everything, like I have to clench and control it all. And like, it's like, there's a human being there. There's a body of a human with emotions and experiences in their life that have come to this moment. They are not here to torment you. It's not about you, and like, it feels like it is, because medicine is, the training just kind of like, I think a lot of times can like beat the compassion out of us, but in different ways, or just change the way we approach interactions with our patients, which is so tragic. But
I think it's just remind people to encourage them to read the literature, because the literature on how to treat pain in sickle cell patients is different than the literature on how to treat acute pain in a patient who hasn't had chronic pain for their entire life.
yeah.
So I think it's important, because it may sound out of the box, like, well, why would I give that much opiates to a patient? Read the literature and you'll find out why.
Yeah. Yeah. And also remembering that this isn't just about pain. There's so many other complications that can happen that are life-threatening. They can be life-threatening. And so this is like real legit deal. This is like, the pain is legit enough, but also like knowing that we have to be on our guard to try to prevent these consequences. And it's life or death, what we're talking about a lot of times. And yeah. Any other last thoughts on sickle cell or racism in healthcare in general? This has been incredible.
Yeah, I mean, I would just encourage, in general, for doctors to take a little bit of humble pie, particularly when it comes to dealing with people other cultures, and recognize that you don't know everything, and that it's okay that you don't know everything. And then also understand that the patient that you're coming in contact with may not trust you. And that's okay too, right? Like our job is not to be the God to everyone. Our job is to at least, at minimum, be patient and understanding. And if you don't have space or capacity to be patient and understanding, ask for help, you know, ask another colleague to say, listen, I'm having a hard time understanding why this patient seems to be so hostile towards me, having a hard time understanding, because sometimes it's not just the medicine, right? It's, you know, I can tell you to read the journal article and you can still do that, and that patient still may not respond to you the way that you want them to respond to you. And so I think it's important that we take a moment, be a little bit more humble, and not only ask a friend, but ask a person of that cultural descent, right? So you can get very far by asking other African American doctors about how they would respond, and see and sort of realize that maybe your response is not the only response. Maybe there's another way. Maybe other people have formulated a different approach to responding to the same issue, and that your blind spot, you might have blind spots on the way that you're responding, and you don't even know them. And the only way you'll know is by talking to other people.
Yeah. Yeah. Like being open to being wrong, which is not something that we take too kindly to as doctors.
Wrong. You don't have to be wrong, right? You don't have to be wrong to realize that I could do this better, right?
Yeah. Or maybe be open to learning. Yeah. Be open to learning and growing. Maybe that's a better way to say that. I'm glad that you.
Because I don't want people to feel like, you know, that, you know, oftentimes when we talk about race issues, white people are scared to ask questions. There's, you know, because they don't want to be perceived as being biased or racist by asking the question. But at the same time, you know, we're talking about patient care here. And so I think the stakes are higher, the same way the stakes are higher in any job where somebody's life is on the line, right? So medicine, policing, politics, I think those are the areas where you really can have an immediate effect on somebody's life. And if you're not willing to get the information, then you may give care that is subpar. And the consequences are too great.
Yeah. Yeah. Well, thank you so much for taking time to chat with me. It was fun to connect with you, even though we're talking business. But thank you for being your beautiful self and sharing your experiences as a mom and as a doctor and as a Black woman, like all of it together. I think this is just, for anyone who hears us, I think it's really going to just like explode their brains in the best possible way of how to take better care of not just our patients with sickle cell, but our any Black patient or patients who are non-white. Just going to raise the bar in terms of the service we provide to our patients. So thank you so much for joining me today. You have it's sort of weird because you're not are there ways people can follow you, or do you want any social media or any websites or anything that or other resources you want to point people to, if it's not you specifically, then, you know, about sickle cell or anything like that?
I would say there are definitely articles that I think there was a study done by Morehouse School of Medicine specifically on sickle cell and pain, or maybe it was Meharry. But one of, I think that the HBCU medical schools.
Okay.
And so I would definitely recommend that. And yeah, for me, you can always follow me at Dr. Nicole Peoples on Instagram, on Facebook, or People's Functional Medicine on Instagram and on Facebook. And yeah, that's it.
Awesome. All right. Thanks, Nicole.